All right, everyone. Thank you for joining us today for blood tests for Lyme disease with Dr. Joseph Burrascano. This is not his first time doing a webinar with Project Lyme, and I'm sure he's well known within the community, but I still want to do a brief introduction. He's a well-recognized specialist in the diagnosis and treatment of Lyme and associated infectious diseases, as well as chronic illnesses that will accompany them. With over 2 decades of experience and research in this field, he has appeared in and on virtually every form of media, has advised the CDC and NIH, testified before the US Senate, an Armed Service Joint Subcommittee, and at various governors' councils. As a founding member of ILADS, he is currently an active board member still at that association. Today, we're going to be discussing a variety of things, but I briefly wanted to introduce the culture-enhanced PCR test from IGeneX. It's a new test that they just came out with, which I know he'll be covering throughout this webinar. So thank you so much for Dr. Burrascano for joining us today. I'll go ahead and turn it over to you.
Thank you, Noah. Let me start sharing the screen. Get this started. And there we go. All right, here we go. All right, let me close my face off so I'm not in the way. All right. Well, everyone, thank you for joining. Today we're going to be talking about testing for the various major tick-borne diseases. And let me just get started. What most clinicians worry about or are concerned about is when testing the sensitivity. You don't want to miss cases if it's not sensitive enough. Specificity, in other words, you don't want false positives, and broad coverage. The need to test all the important pathogens that may be affecting the patients. So what I'm going to do today is give a very deep dive into the mechanics and the details of each different testing method, what they are, what they mean, how they work, when it's best for them to be used, when they're most sensitive, when they're least sensitive, talk about what's been out there for many years, and now talk about the new things that are out that are definitely much better. So I'm going to start in terms of general discussion of the testing methodologies, and then I'll go through the individual diseases after that, and hopefully I'll have enough time to cover everything. Here we go. All right, a lot of Lyme tests and tests in general tick-borne diseases are based on immune response. So I want to show this slide to give us a background. The T cells respond to an infection the earliest before the B cells. So T cell response assays are most sensitive early in the infection. If you look at the graphic, that's reflected by the blue little rise here. So in the very early stage of infection is when the T cell response is most active. It then does generally drop off. In some patients, it'll stay reactive during the mid stage of the disease, but also in a number of patients, it will start to rise again in sensitivity as the illness becomes chronic. When it comes to B cell response, that's IgM and IgG. The IgM reacts first of those after the T cell response, but it's the first of the B. It will peak early and then drop off again. But just like the T cell response, it may persist, especially in Lyme disease Borrelia. And again, may start to rise later on. Many people have said that positive persistent IgM can't be real. It's got to be a false positive. I'll show you data to show that with the newer tests and the better tests, it's not the case at all. Also, there are articles many years ago showing that the infection by Borrelia will prevent the conversion of the IgM response into IgG response. So this is actually well known and published. The IgG does appear last. It may drop off, it may persist. And in fact, in late chronic infections, you do see it drop off because of damage to the immune system by the infection. We'll talk about that. And that's the paradox I mentioned at the end. The more ill the patient is, the less likely they are to have a positive IgG response. So we'll talk about how those serologies are made. So first you have to get antigens from that organism that you want to test for. And you use these to create a system that you then mix with the patient sample, the blood or whatever. And if the patient sample contains antibodies, then they're going to bind to the antigens in your system. Now you have to design the system that will indicate that this has happened, so you know that this is happening. It could be a color change, which is what happens with the ELISA. It can be a fluorescent, which is what the IFA is all about, or it can deposit a dark spot on a test strip, which is what a Western blot and immunoblot does. So for this to work, first of all, you need highly purified and very specific antigens for each organism, which also have to deal with background noise and cross-reacting organisms. Because of this, there's a trade-off between sensitivity and specificity. The IFAs and ELISAs were the first tests to come out for the tick-borne diseases, and their antigens that are needed come from either a whole cell sonicate, in other words, you take the organism and bust it up into pieces, usually by ultrasound, and then you use all the stuff that's in that soup. Or you can choose a specific antigen. As an example, in Lyme disease itself, in Borrelia, you can either use a sonicated whole Borrelia, which is usually the lab strain, B31, not a patient strain, or you can use just a flagellin antigen, which is the P41 on the Western blot. Another example, in tick-borne relapsing fever, when you order an ELISA from the big labs for Miyamoto, they only target one specific antigen, the GLPQ. Now, whole cell is too non-specific because you got a lot of different antigens that have a lot of risk of cross-reactivity. The single antigen is very insensitive because not every bacterium or parasite reflects or manifests every single antigen. So for example, Lyme, P41 as the sole reagent is not specific enough because a lot of spirochetes, in fact, most of them express P41 and some other bacteria do as well. Another example, C6 ELISA, not really used much anymore, but that's not present in every single strain of Borrelia burgdorferi, so it's also very insensitive. The other problem with these, both the IFA and ELISA, is it only can test for one species at a time. So if you're dealing with the tick-borne diseases that we're seeing nowadays, where there are a whole bunch of different Borrelia involved, with Bartonella, a whole different Bartonella involved, you would have to have dozens, literally, of different IFAs and literally dozens of different ELISAs to get some accuracy, and that's not being done. Western blot, they should be better because they display not one antigen or everything. They use multiple ones, and then allows us to choose which ones we want to record, which ones are more specific. There are several problems. First of all, again, they're made from cultured lab strains, and lab strains are basically based on strain B31, which came from a tick, was kept in culture in the labs for decades, literally. And over time, it's different. It changes over time, and it's different from what we're seeing in real patients. So again, in the Western blot, they lyse the organisms, releasing many, many antigens, some of which are non-specific. Again, one species at a time. Because in Lyme, the Western blot is based on the single lab strain, not only does it not reflect the whole breadth of Borrelia burgdorferi sensu-lato, all the different species of Lyme Borrelia, but it doesn't reflect any of the important tick-borne relapsing fever species. So you're going to miss all of that. Now, in the case of Lyme disease, CDC, insurance companies, among others, insist upon using the CDC case definition surveillance criteria that specifies which bands you should include, which bands you should ignore, and minimum number of bands you need to use to call a test positive. These criteria are meant for surveillance and not for diagnostic purposes, so they should not be used for diagnosis. Again, as you can see, you're going to have poor sensitivity, poor specificity, and you're not going to cover all the different species. The immunoblot is the one serology that's different. It's fundamentally different. It doesn't use lysed organisms with the whole soup of organisms that come out of it. It uses recombinant antigens. These are antigens that the lab will choose to use. They're very highly specific, and it eliminates the noise created by all the non-specific antigens that come from lysing an organism. And also, instead of being put on the strip by electrophoresis, which is kind of an inexact process, which is what happens in a Western blot, here they're using what's basically an inkjet printer to print the strip in exactly the right area, exactly a specified area, and exactly a specified amount of antigens, so that when you have a result like you see in the picture here, it's very, very clear. I'm going to go back to the, I'll go forward. Okay. Now, I talked to you about the immunoblot being better and different because it uses recombinant antigens. Well, what is that? Recombinant antigens are lab-created proteins that are identical to the ones in the organism. And you can specify exactly which ones you want. Now, how do you do that? Well, it's kind of reverse engineering. What they do is they take the DNA sequence in the pathogen that codes for that protein, then they incorporate that into a host, usually E. coli. They grow that in the lab. The E. coli produces the pure protein antigens, and that's what's used. In the Igenix immunoblot, they use a broad array of these proteins, very carefully chosen, and that results in the increased specificity, increased sensitivity, and more importantly, very broad species coverage. You're not restricted to just lab strain B31. You have the whole Borrelia burgdorferi sensu-lato. You have multiple species of Bartonella, multiple species of Babesia when they do those tests. So the advantages, the highest sensitivity and specificity of any serological test, and I'll show you the data on this when we get to the individual organisms. And basically, if free antibody is present, you're going to get a positive result. So you can rely on this. Also able to detect multiple species. In Lyme, all of Borrelia burgdorferi sensu, which is the whole spectrum of Borrelia that infect people all around the world. In tick-borne relapsing fever, you can detect all the major pathogenic species that are known to exist, at least in the United States patients, and then also many other places. With Bartonella and Babesia, you can detect multiple species, and the major ones can actually be identified by name. There are other considerations with serologies. A positive result means that free antibody is present and has been detected. In other words, serologies look for antibody, but not everybody has free antibodies. Now, why is that? Number one, there's a condition called antigen excess. If there's a lot of antigen, a lot of organisms, the antibodies that are present can be bound up in what are called immune complexes. And it's like a lock and a key situation. So what happens is the antibodies are bound and none of them are free. And because serologies are meant to detect free antibody, you can get a false negative. If there's an immune deficiency, if the patient's not making enough antibody and may not be able to be detected, you can get a false negative that way. And stealth organisms are those organisms that can hide from the immune system and not elicit an antibody response. And that is one other cause for seronegativity. The T cell response assays, like serologies, they reflect past exposure to an organism, but here they measure T cell response. What they do is they take the patient's blood, very carefully handled and processed and mailed, so it arrives in the lab with the T cells still alive, still viable. Then what they do is they add the antigens from the organism to be tested into the cell culture where the T cells are. Now, if the T cells have been previously exposed to the organism, that means they're primed. So when you put these antigens into the system, the T cells activate. And what the lab then does is it can assess the activation by either incorporation of a radiopharmaceutical or by liberation of interferons, and they can measure interferons. The ELISpot method, which is what's most commonly used, is the one that measures liberation of interferons, as in the IGX spot test from IGeneX. Clinically, as I showed you before, the reactivity of the T cell responds very, very early. It does taper off, but then it may reappear late and in chronic infections. And because T cell responses are really pretty much independent of the B cell response, you can have a positive T cell response in someone who's seronegative, especially in very, very early or very, very late cases or people who have B cell dysfunction for a variety of reasons. These can be designed to detect different levels of organization. And in the case of what IGeneX does, they do genus level. So if you get a Borrelia positive, it'll cover all the different Lyme Borrelia, for example. It broadens the coverage. Here, the sensitivity and specificity is about 80% when it's tested within the desired time window. Again, go back to that graph I showed you. Very, very early on is when it's really good, and late when B cell dysfunction is prominent, it's when it starts to get good again. Another trick, which I think is really helpful clinically, and I haven't seen a lot of people doing this, I like to help my patients by assessing their immune responsiveness. How do you do that? Well, here, very simple. You order a B cell based test, a very good one like an immunoblot, and a T cell response assay like this one, and you see what shows up. If someone you know is infected has a positive B cell response and not a T cell, or positive T cell, not a B cell response, you start to think that maybe perhaps they have an immune deficiency going on. So in other words, it's not only for helping you to diagnose your patient, but helping you assess their immune responsiveness. Another method is antigen capture. This is a direct assay, usually urine, occasionally spinal fluid, and it looks to detect the presence of antigens from the organism. This is only available for Lyme disease at this point. And you can use one or several antigens. For example, the Lyme blot from IGeneX, that is multi-species, Borrelia burgdorferi sensu, and it uses multiple antigens, 31, 34, 39, and 93. Galaxy offers an antigen capture in the urine called the nanotrap that likewise is multi-species. However, they only use one antigen, the B31. When do you use this? Well, very helpful when it's very hard or impractical to draw blood. For example, someone's got poor venous access, people who are refusing or needle shy, and especially newborns. You know, when I had taken care of pregnant women, when they finally delivered, pregnant women with Lyme disease, when they finally delivered, I wanted to test the babies for the first 6 to 12 months of their life, test them for Lyme disease, and very simple to collect the urine on a baby, much easier and actually more accurate than collecting their blood. But this is the thing, the antigen spillage into the urine is not constant. There's a lot of variation. Some days it's absolutely zero, other days it's sky high. The thing is that the sensitivity and the spillage tracks the symptoms, okay? When there are symptom flares, when there are Herxheimer reactions in women during the menstrual period, that's when there is more antigen being spilled. So to take advantage of that, some clinicians will pre-treat patients with an antibiotic to induce a Herxheimer reaction and then collect the urine. Often what they'll do, and what I had done all the time, is collect not one, but 3 samples to increase the yield. And such a thing is, because these are very, very specific, but only intermittently sensitive, if there are 2 or 3 tests that are positive, 1 and 2 is negative, you believe the positive. The only thing about specificity here is that sometimes urinary tract infection can give a false positive. So it's routine to do a urinary culture and UA at the time the urine is collected for this antigen capture, just to be sure. Okay. Next one is the FISH, the fluorescent in situ hybridization assay. This is a direct test that measures the presence of the pathogen by the RNA, not the DNA, but the RNA. And again, it's a direct detection test. What they do is they take a drop of blood, they spread it out on a glass slide, and they put a fluorescent stain on that's attracted to the RNA of the organism. And then they look under the microscope. So it's a really great direct test. You actually can see with your own eyes what's going on. You can take a picture of it if you want. Other thing about this, being that's an RNA test, if you know, RNA does not persist post-infection. Some claim DNA does, but RNA does not. It disappears within minutes after the pathogen dies. So here, a positive test means the time the blood was taken, person was infected. Another thing really important about a FISH test, and now that we know about biofilms, if the organism is embedded in biofilm, even then the FISH will detect it. In the case of the Igenix FISH testing, they offer it for a number of different things. It's genus specific, so it's very broad coverage of it. You don't get a name of what's there. They might say Bartonella species or Babesia species, but a positive is a positive. Clinically, pathogenemia, which is what you're measuring here, is highest early in the infection before effective immunity develops. So very early in disease, you can get a positive. In fact, within, literally a day after infection with Babesia, you can get a positive FISH. Also, very late in the infection, pathogen load can increase as immunity declines and organisms adapt to the host. This is another time the test is very helpful. Again, it's very, very highly specific. I mean, you're actually seeing this with your own eyes in the microscope. So a positive result should not be dismissed. Negative doesn't mean you don't have it, but a positive, definitely you cannot ignore that. And in some proficiency testing that was done by one of the states, the Igenix FISH was 100% specific. PCR, that's a direct detection assay also. This one looks for the presence of the nucleic acid, usually DNA though, not RNA, of the organisms in the specimen. And you can test blood for sure, but other body fluids such as urine and spinal fluid can be tested, and also biopsy samples. So if someone's going for surgery and having a biopsy done or having a joint replacement or placenta even, this is when you want to test the biopsy sample. Now, enough DNA is found, you can actually do direct sequencing to confirm the identity of the pathogen, but often that's not the case. The better labs use a genus level detection, which is Igenix and Galaxy, for example, because this way you get the broadest coverage. And PCR testing is actually available for most of the tick-borne diseases and many of the viruses, Borrelia, Babesia, Bartonella, Ehrlichia, Anaplasma, Rocky Mountain, and others. And sensitivity, though, is poor for PCR, at least in the blood. Why is that? In the blood, there are PCR inhibitors that prevent this reaction from happening in the lab. Things like heparin, host DNA, even hemoglobin can inhibit this. The pathogen load also is often very low and maybe too low to detect, especially because of the inhibitors. And that's because these pathogens, although they do transit through the blood, it's often intermittent. And when they are in the blood, they're sometimes attached to biofilm or attached to cells, and they can't just be picked up that readily by a PCR. So what do you do to make the PCR more sensitive? One is you draw more blood, larger blood volumes, not one tube, but several or larger tubes. Some labs recommend you draw the blood on several different days, like once a week for several weeks, just so you have a lot more sample. Next trick is you test when the pathogenemia is expected to be the greatest. Now, this varies by pathogen, but basically As you can expect, during symptom flares, when the patient is more ill, that's when the pathogen level is generally higher. If the patient's on antimicrobials, be it antibiotics or even herbals, in my experience, it makes the PCR less sensitive. So it's recommended that you don't waste your time and the patient's blood and money doing a PCR if they're on treatment. Now, I would never recommend you stop treatment just for the sake of a test. I mean, you want to take care of the patient. Just so you know, if it's someone who's been off treatment or hasn't been treated, that would be a better time to do it, not during treatment. Another way to get around this problem of lack of sensitivity, use fluids that don't have lots of inhibitors. Spinal fluid is pretty clean. Urine, however, does have some inhibitors, not as badly as blood, but there are some problems with doing urine PCRs as well. How about removing inhibitors? Well, that can be done. And when I talk about the IGeneX culture, that's what they actually do. Careful specimen preparation, pre-culturing can help to remove that. And finally, as I mentioned before, don't test the blood, test tissues. Perfect example, if someone's having an orthopedic diagnostic test, like a tapping a knee, for example, knee fluid, synovial fluid is not that sensitive of a place to test, but during the course of doing the sample, they can take a synovial biopsy. It's just a different type of needle, and that's much better for a higher yield. I mean, the range goes from 5% to 40%, if I remember the literature correctly. Let me come to the culture. Culture is the gold standard. I mean, anytime you have something really wrong, you got to do a culture. But until now, you really haven't been able to do cultures for the tick-borne disease. There's a lot of technical problems. First of all, the tick-borne diseases, these bugs are adapted to thrive in living organisms. They're not adapted to live in an artificial culture dish. So that's one big hurdle, especially something like Bartonella, which is an intracellular organism most of the time, and Babesia likes red blood cells. How's it going to live in a petri dish? Second thing is that, as I mentioned before, pathogens are not always present in the blood sample. And finally, if you're going to draw blood and grow them in a culture, it's not like a strep throat or urine culture. You can get a result in a day or two. Tick-borne diseases grow very slowly. I mean, the doubling time for Borrelia is measured in days and weeks, not hours. So the culture may have to be extended over many weeks before you can actually get a reliable result. And often you don't like to wait that long. The flip side of that is if you wait a long time, a long culturing interval, other pathogens that might have been present in the blood sample can overgrow and spoil the culture. Then you have nothing. So that's a big problem. Next thing is, all right, let's say you've cultured something, and now it's a couple of weeks have gone by, and you say, all right, let me look at what's going on. How are you going to confirm what that is? Just because you see something swimming around? Well, that is not too accurate. So that's always been an issue. And there are ways of getting around that. And, culturing is difficult. There's a lot of complex methodology involved. It's labor intensive, time consuming, the risk of contamination, all this thing about holding samples for many weeks. You have to have a lot of big refrigerators and incubators and all that. So it's a big upset for the lab. But IGeneX has now been able to develop a culture, not just for Lyme disease, but for tick-borne relapsing fever as well, for Bartonella, for even Babesia, Ehrlichia, Anaplasma. Never before could you culture Babesia, Ehrlichia, Anaplasma clinically for your patients, but now they've been able to do it. Took a couple of years of research at least. Many hundreds of samples were used and tested and retested. And what they did is they developed these culture media that's secret, lab secret. I have no idea what's in it, and they won't tell anyone. And they keep the blood for 2 weeks in culture, and after 2 weeks, they sample is tested by PCR. It's important to say that you don't want to just look again at the microscope and maybe make a smear. What you want to do is actually test by something that's pretty validated. And we'll go into the validation in a second. When they do the validation by PCR, IGeneX does, again, a genus level. So it broadens the number of pathogens, makes you much less likely to get a false negative. You just want to identify what species is present. It'll say Lyme Borrelia. It won't say Borrelia, Burgdorferi or whatever. The other thing is that each different pathogen requires a different culture medium. In other words, you can't culture Babesia in the same blood sample that you culture the Lyme from. So you have to get separate culture tests for each individual organism. So how did they validate it? Now, this is the big thing, because, so many critics of cultures over the years have said, oh, it can't be, it's contaminants, it's, just lab schmutz. Well, there are different ways of different choices of what you can do. What they did at IGeneX was use PCR. Well, it's available technology, it's proven technology, it's something people understand and accept. But you had to optimize and validate this before people will believe it. In the case here, they remove and neutralize the peripheral blood inhibitors, and they rigidly standardize and control the PCR process. I'll give you an example of that. When they did the development, every single positive PCR sample was sent to an outside reference lab for sequencing to confirm the identity. So it wasn't just a positive PCR, every single one was sequenced. In addition, what they did, they used their recombinant technology to make reverse Western blots to see if the reverse Western blot picked up the same organism that they're picking up on sequencing. So that's a really wild thing that no other lab has ever done, as far as I know. And this is what they found. Every single sequencing result exactly matched the initial PCR, and every single reverse Western blot exactly matched the results of sequencing. So the specificity is there. I mean, basically, with this level of validation, it's basically 100%. The thing about sensitivity, though, is you really can't report that because there's no gold standard other than the culture to compare the culture to. So I really can't give you numbers. In the literature, there's a lot of different measures of culturing, enhancing the sensitivity of a PCR, and the range goes anywhere from 30 to 40% up to as high as 94% sensitivity based on different methods. And I can't say what it is for this one because we just don't have the data on that. But the bottom line is, if something is growing in culture, it's guaranteed to have been an active infection the time the blood was drawn, not a remnant of a past infection. So it's an active, ongoing disease at that time. Again, it's a genus level diagnosis, so it's giving you very broad species coverage. In fact, it's so broad that some very interesting things showed up. One is a case of detecting a positive anaplasma blood culture. So when it went out for the sequencing, it was found to be Anaplasma platus. What the heck is that? Well, it's a tick-borne anaplasma. It's normally an intracellular, which is cool because it means that they can culture intracellular bacteria. And it's normally infecting platelets, not the white cells, but platelets. And in dogs, it results in an infection that causes cyclic thrombocytopenia. There has been a report of A. platus in hard ticks in China. And also there are reports of this infecting cattle. And if you look through the literature, which I did, there's only 4 cases in the world literature of human infection by this. And yeah, they picked one up just randomly doing their validation. So I guess if they report this case, it'll be 5 cases in the world literature. So just an example of how this thing's picking up stuff that you would never otherwise expect. Now, if you were doing an anaplasma serology, I really don't know if it would pick up platus. It was never, these serologies are not designed for, you know, these rare things, but the culture picked it up. Now, is it FDA approved? Well, at this point, it's not. But the thing is that FDA approval is a licensing procedure. It's not a test of validation or accuracy of a test. It's a licensing procedure. So you can market the thing and make it into a kit that you can sell to other labs. Now, in the case of Lyme disease, the FDA approved test kits, which everyone seems to say, you know, you have to use, they're based upon lab strain B31, not a human strain, not a current strain that came from an infected patient. So these are notoriously known for their insensitivity. And I'll give you some information on that in a second when I get to Lyme. So here we have a case of an FDA-approved kit being much worse, much less accurate than a lab-validated test, such as immunoblot or the culture. In fact, validation is done by CLIA, Medicare, individual states, and College of Pathology. So again, lack of FDA approval does not mean inferior test. So if someone says, I don't believe that because it's not FDA approved, you can laugh at them because it means, in fact, an FDA approved test may not be as good. It may, in fact, be worse. Okay. So let me summarize. Using indirect tests, this is what's recommended. The indirect tests are the different serologies and T-cell response assays. The best time to use them is when you expect the immune response to be the highest. So if it's early disease, that's when the T-cell response is the highest. Immunoblots are really good early on too. If it's disseminated disease, but not really chronic and intact immunity, immunoblot, the T-cell response at that point is not going to be that strong. However, late in chronic infections, definitely immunoblot because it's the most sensitive serologic test, and the T-cell response assay in some people does become sensitive again. Now, if you have a patient who has an immune deficiency, either proven or suspected, then you can add a direct test just to bolster this. But again, even if someone is known to have immune compromise, I always recommend do both an immunoblot as well as a T-cell response because you're going to see changes as treatment goes on. In fact, it's well known and published, and I've seen it myself, my own patients, that a patient who's seronegative during treatment and after treatment will start to have a stronger antibody response with more bands on the Western blot, a higher level on antibody levels. And someone who's seronegative can become seropositive. Someone who's seropositive can get stronger positivity. So you can actually use that sequentially as a sign that your treatment is working. Remember, we say you can't do a serial test to see the treatment effect. But in the case of someone with a weak immune system from chronic disease, who's either seronegative or has a very weakly reactive immunoblot, you can do that serially and see over time when it starts to show reactivity, then you know that they're starting to recover, and that's great. All right, how about optimizing the testing with direct tests? The direct test is a culture, the FISH, urine antigen capture, and PCR. Here, the key is to use them when the pathogen load is expected to be the highest, okay? The highest load is early in the infection before immunity has developed. Also during symptom flares. This is when Borrelia infections have their 2 to 4 week cycles, for example, specific times a day. What I found in my early culture experiments with Alan McDonald is that in Borrelia, early afternoon, and especially during a chill phase of Borrelia, is when people are more likely to have a positive blood culture. In babesiosis, there are cycles and chill phases. Likewise, that's the time to do it. For Bartonella, nobody really knows at this point. I have a feeling it's in the morning, but I really can't say. I haven't had enough experience with that. Again, antimicrobials, if someone's on treatment, they have to be off treatment for long enough time for the organism to reemerge. In the case of Lyme, my experience has been at least 4 weeks, and 6 is recommended. But again, do not stop treatment just for the sake of doing the test. Okay, you don't want to hurt your patients just for the sake of a test. Use your clinical skills. Now, if someone is not already on treatment, some clinicians recommend you do things to try and enhance the sensitivity of the test. Physical measures, saunas, massage. Some people actually give antibiotics and maybe break up the cells and release some more antigen. That's not been validated. That's kind of anecdotal, but still you might hear that, and it is a popular thing to do. All right, as promised, I want to go through the individual illnesses one at a time. With Lyme, it's the most common vector-borne infection in America. It can live in tissues, inside cells. It does transit through the blood. People say it's not blood-borne. Well, how ridiculous is that? How does a tick get infected if it's not in the blood? Ticks drink the blood, and that's how they get infected. Lyme is known to evade host immunity. It will inhibit and kill B and T cells, especially in the chronic form. That's why late Lyme patients have a weakened immune response. Also can inhibit the maturation of killer cells. They don't switch from CD56 to CD57. So that's why you see in a lot of Lyme, especially chronic Lyme, a low CD57 count. They can shift into different morphologic forms, helps to evade immunity, resist antibiotics, make testing a little bit more difficult. And it can go into a stationary phase, which again, further evades immunity and antibiotic treatment. It can persist, can become chronic, even despite antibiotic treatments. And as I explained before, lab testing, especially the older lab tests, can miss some cases. I want to mention again that dissemination of Borrelia can be very rapid. As soon as a tick bite allows the pathogens to get to the bloodstream, they're carried by the blood to everything, including the central nervous system. Now, it's been said that not everybody has CNS Lyme, and I completely disagree with that. If you have blood in your brain, and I hope you do, you're at risk of having CNS Lyme if you're infected. Why? It's bloodborne, especially more so early on. It burrows between and through endothelial cells. It's not blocked by endothelial barriers or blood-brain barriers. In fact, it's been shown through animal studies that you can find Borrelia in the CNS within hours to days after the tick has hit the bloodstream. But spinal tap testing is very, very inaccurate. I'm quoting this from Dr. Pat Coyle at Stony Brook. During one of her lectures, she said in her series, cases of Lyme meningitis, which is the most acute form of CNS Lyme, only 9% had antibodies in the CSF. In other words, 91% false negative. How do you like that? So my summary is that all cases of disseminated Lyme involve the central nervous system, and a negative spinal serology does not rule out CNS infection. And because of that, neurologic Lyme is really underdiagnosed. I think it's a matter of case definition and calling neurolyme those who have positive antibodies. Well, that's really stupid. It doesn't make any sense biologically or physiologically, and not in her experience either. Immunosuppression Borrelia, this is a picture of Borrelia invading a lymphocyte. It can inhibit and invade and kill the cells, the Bs and the Ts. So you can get a weak serologic and T cell response, seronegativity, T cell test negativity. So the culturing is a solution because you can directly detect the presence of the Borrelia independent of the immune response. In fact, if someone does have inhibited immune response, they're going to have a higher germ load then because the body is not able to contain it as well, and you're more likely to get a positive direct test. But again, I would still order immunoblot testing for the B cells and the IGX spot for the T cells to see what's happening with the immune response and to have something to follow as treatment continues. So about lab testing. The indirect immune-based tests are the standard serologies, the IFAs, and ELISAs. We're going to talk about their limitations. A new test that was just introduced last month by IGeneX is Lyme screen immunoassay, which is far better than the ELISA and IFA, and I'll show you the data. The Western blot we talked about, the immunoblot we talked about, which again is a gold standard for serologies, and the T cell response assay, which I don't think is being done as much as it should be. For direct testing, we have the culture, which is a culture-enhanced PCR, which basically replaces Lyme PCRs unless you're doing tissue biopsies, and the urine antigen capture, which in case of IGeneX, you can also do on spinal fluid. So the IFA and the ELISA, again, it's either whole cell sonicate, usually what's happening in America. Some European labs still use just a flagella and the P41. The IFA is seriously nonspecific. You can get a false positive from oral flora, from syphilis, from a lot of the DNA viruses and so forth. So it's very nonspecific. And there have been a lot of cases I've come across of people who have positive IFAs but negative immunoblots. And in this case, you definitely would believe the immunoblot and disregard the IFA. However, look for other things like Epstein-Barr that might be giving this false positive. The ELISAs are also very poorly specific because the basic technology is the same. It's just the way the thing is read. It's read by a machine, not by a technician under the microscope. So they're not insensitive. They're not very specific. Here's the data on this. This was published a number of years ago by Ray Stricker. He summarized results of 9 different studies on sensitivity of the ELISA. You see it's around 50%. He says the average is 49%. And because of this trade-off of sensitivity and specificity, if you change the parameters of what you're calling a positive and negative test to make it more sensitive, like here, 75%, look at this specificity drop down. So that's the trick here, or the limitation of these serologies, is this trade-off between sensitivity and specificity. This is what I talked about just before. The IGeneX Lyme screen, this basically replaces the IFA and the ELISA. Why do this test? Well, first of all, it's better than the IFA and ELISA. And second of all, some people's insurance still require 2-tier testing. So you can use this as tier 1, immunoblot as tier 2, and that way you get much better results. Now, these are results that came from them using samples provided, blinded samples by the CDC itself. Early Lyme, 75% sensitivity in what CDC calls neurocardiac and Lyme arthritis, what they call so-called stage 2 and 3 Lyme. They found 100% sensitivity using CDC's own samples. In terms of specificity, 93.8%. I mean, this is far, far better than any ELISA and IFA out there. So this is your new go-to for screening. In fact, what IGeneX has done is they basically replaced the Lyme AFA screen in all their panels with this new test. And that's the same cost as far as I heard. Again, the Western blot, you know, it's old technology. Remember I said what they do? They sonicate and lyse the Borrelia, and then they put it on the strip. Well, look at all the different antigens that come out. This is a test sample. This is just the raw material you're getting out of the test strip. Look at that. It's just so much scatter, so much noise. So what they do is they sonicate the thing. They put it in a bath. They electrophoresis it on the strip. They add the antigens. If the antigen is there and the antibody is there, they're going to match up and give you a band. And so you interpret it by saying, is a band present or not? And if it's present, what band is it? And is it a strong band like these? Is it a weak band like some of these? If it's really weak, how do you know if you even believe it? If it's really strong, is it one band or two mushed together? You know, so interpretation is kind of dicey with the Western blot. Disadvantages. The band locations, depending on where it ends up after electrophoresis, which is not very exact. There are a lot of non-specific antibodies in this mush, so confusion with that's possible. The band intensity is dependent on the culture this thing came from, and some cultures are great. You get a lot of bands and strong dark ones. Some cultures are not so great, and you get a weak bunch of bands. And what can happen is you get false positives and false negatives from that one thing alone. And again, with the Western blot, you just test in one species at a time. And overall sensitivity is about 50 to 70% based on which lab you use and who you ask. Now, the CDC has developed interpretation criteria for the Western blot. These were, again, for epidemiologic surveillance and not for clinical diagnosis. Problems. First of all, they include bands which are not specific to Lyme, so it makes rise to false positives. They exclude bands that are very specific to Lyme, gives rise to false negatives. And because of that, the accuracy is very low. And the bottom line, again, is don't use CDC criteria when you're helping to diagnose a patient. It's only for surveillance. The other thing that's come up is what's called two-tier testing. The idea behind this is to have a very, very sensitive screening test. So sensitive, you're going to pick up everybody, but at the cost of maybe some false positives. So to get around that, anytime you get a positive, to exclude a false positive, you do a second test, the second tier, which is just as sensitive, but much more specific. And that way you can weed out the false positives, okay? So here, if the first test is positive, you do a second test. If the first is negative, you don't do the second one, and that's it. Now, for this to make sense, the first test has to be at least 99% sensitive, okay? And the second should be as sensitive, but also at least 95% specific. Now, right away, it makes no sense. If the second test has to be as sensitive, but more specific, why do the first test in the first place? It makes no sense. Now, when you apply this to Lyme disease, according to the CDC, it's supposed to be with an IFR analyzer, which I just showed you has only a 50% sensitivity, not the 99% you need. And the Western blot or another ELISA is tier 2, which again is not 95% specific. Okay, so you're going to miss at least half the cases with this. And if the CDC is doing this two-tier, they use their criteria for interpreting the Western blot. So again, tier 2 becomes kind of useless. So if it's being done, it's for surveillance and not for clinical diagnosis. If your patient's insurance or other people involved need to have two-tier testing, do the IGeneX Lyme screen as tier 1 and the immunoblot is tier 2, and otherwise you get around all this. Okay, and again, some insurance companies need this, and the solution is to use the Lyme screen instead of the IFA or ELISA and the immunoblot as a second tier. I want to mention this. I keep talking about broad coverage. Well, these are on the left of the screen. These are the Lyme Borrelia that we know are present in America and in other countries as well. In red is Burgdorferi B31, which is the FDA test kits, which is what the big commercial labs use because they use test kits. For all these other ones, 297 is a human strain in IGeneX's Western blots in addition to B31. But this Californiensis, we only have Zelia green, all these other ones. And that's what they call Borrelia burgdorferi sensolata, BBSL. BBSS, senso stricto, is just B31. So what you want to do is have a test that will do all the Lyme Borrelia, not just the lab strain. When it comes to tick-borne relapsing fever, you can get a test for Hermsii, which is just an IFA. You can get an ELISA with one antigen for Miyamotoi in the commercial labs. But all these other ones, and even more, can be present, and they're not tested for by the big commercial labs. Okay, so that's been a big limitation until now we start to get to the newer tests. So in the immunoblot, as I said, it replaces the Western blot. It's recombinant. It's able to detect Ig and IgG even in early Lyme. And I have data that shows in case of early Lyme, CDC samples, their definition of early Lyme, this picked up 93% of cases. There's no serology in the world that'll pick up 93% of early Lyme, okay? Second thing, I mentioned positive IgM. Positive IgM in an IFA, late disease, can be Epstein-Barr, can be anything. But if you're using an immunoblot, they found that even in late disease, the IgM itself is 97%, actually a little bit over 97% specific. So no longer can a late positive IgM be dismissed, okay? Again, a lot of us clinicians, we've seen a positive IgM late, and then they say, oh, it can't be Lyme, it's a false positive. Well, if it's an immunoblot, that's not the case. You've got a 97% chance that's real. Okay, as I mentioned, I want to go into this because we're running low on time. So what happened was blinded testing was just done, just reported like a month or so ago, again, using CDC supplied test samples, positives, negatives, other illnesses, early Lyme, later Lyme. And this time they used IGeneX lab criteria, not the CDC criteria. The result of the Lyme immunoblot, 100% specificity, not a single false positive, even though they're using IGeneX criteria, which they say is not good. Well, no proof that it's good. Sensitivity here was 90%, agrees very well with that 93% I told you earlier about before. Okay, another perfect example of a lab-developed test, which is far superior to an FDA-approved test. Tick-borne relapsing fever. Why is that a big issue? Well, if you read about it in the textbook, they talk about this dramatic presentation with high fevers and sweats and comes and goes every few days. And it's very dramatic and it's a relapsing fever situation. The problem is there are a lot of people who actually don't have Lyme, but tick-borne relapsing fever who present just like a Lyme patient. They have the malaise, the headaches, the fatigue, the joint pains, and all the other things that go along with it. Okay. The problem though is that if you're testing these supposed clinical Lyme patients with a Lyme test, you're not going to be able to pick up tick-borne relapsing fever. Now, here's the data on this. Not one or two, but 543 patients in the United States were tested. These were referred to the lab by the clinicians with a suspicion of Lyme disease because they presented like Lyme, not this relapsing fever picture. 32% had antibodies for Lyme, 22% had relapsing fever antibodies and not Lyme antibodies, okay? 22%. And 7% actually had both. And I know of patients who've had both relapsing fever Borrelia and Lyme Borrelia in their blood. Again, they all resembled Lyme patients. So the conclusion here is that if you have a Lyme patient and you're going to do a test on them, you have to include relapsing fever Borrelia when you're doing the Lyme test. And if you look at the maps, they overlap. So you can't say, well, you know, I don't live in a relapsing fever area. Well, if there's Lyme, there's relapsing fever there pretty much. Look at the map, even Alaska and Hawaii. What about this? Can this be seronegative Lyme? Well, absolutely. None of the commercial test kits for Lyme, the IFAs, ELISAs, Western blots, PCRs, or even T-cell tests for Lyme have ever been validated for all the other Lyme Borrelia or for any relapsing fever Borrelia. And commercial relapsing fever serologic testing has only been validated against one or two species, and each is a separate test. But the immunoblots from IGeneX have been validated for all these different species. And in fact, they can pick up species not even listed there, and they'll just say it's a positive immunoblot where you don't have a species on it. Likewise, the culture will also go at a species, at a genus level, and identify all the different ones or detect all the different ones. So we're going to summarize for Borrelia. Always test for both Lyme and relapsing fever for initial diagnosis and for reevaluations. Use tests that can detect the broadest range of species. That's a very important. I can't say that enough. So we're talking about the immunoblot and the culture, the Lyme antigen captured by IGeneX, the dot blot assay is what it's called, and the T-cell response, because they're all genus level. And for relapsing fever, it's got to be immunoblot or culture because that's the only ones commercially available that are giving you that broad coverage. And also because you can't tell how people are going to respond with their immune system and what their antigen load is, or the pathogen load. It's always useful to use a direct test like a culture plus an indirect test like an immunoblot. You can always add antigen testing of the urine, T-cell response if you have to. And if you're going to do a biopsy like a synovial biopsy, then you do a PCR on that. Rushing to Bartonella. Well, we know it's in at least 49 states, and this is a map just based on where positives were found in a lab test. It doesn't mean that it's not in Nebraska, for example. It probably is. In fact, I'm sure it is. It just hasn't been shown in this one series. But it has been shown in northern Alaska, Hawaii, and everywhere else. All right, so it's in at least 49 states. We know at least 40, 45 species exist. You can get co-infected with more than one species of Bartonella. Fleas, mosquitoes, biting flies, mites, red ants, ticks, animal bites, scratches, needle sticks, maternal fetal. So many different ways you can be exposed to this and get infected. And that's why it's such a big problem. With testing, yes, you get an IFA, as you now know, it's old technology. If you do order it, it's only for the one species, Bartonella hansleyi. Immunoblot, it's much more sensitive. It can detect multiple species, and it definitely replaces the IFA. Here for Bartonella, you can get a fish. And again, it's a direct test, and it's genus specific, so you get broad coverage. But it also, as I said, can detect organisms hidden in biofilms. And Bartonella does really very much hide in biofilms. So if you're going to do a Bartonella test, make sure fish is part of the list of what you're doing. The standard PCR for Bartonella is notoriously insensitive. Sensitivity in one published study is only 6%. Culture enhancing improves that by a factor of 6 to 10, at least in that study. Definitely replaces the standard PCR. I mean, don't even do the PCR on Bartonella. If it tests only 6% pickup, it makes no sense. So the recommendations, because of stealth features, no single test is 100% sensitive, and multiple species are present, okay? So you need very high sensitivity and very broad species coverage. Therefore, you really need to test by multiple methods. You want to do a direct and an indirect test, like an immunoblot. Direct test, you want to do fish or culture, and maybe both. I know in my practice, it always was test with everything you've got because it'll show up in one and not in another. If you know the person has a B cell functional deficit, well, you can substitute the T cell response assay with the immunoblot. But in other words, you don't not do it, you just use a different type. Babesia, very similar story. It's a malaria-like intra-erythrocytic parasite, although they can really swim in the blood as well. It's the most common co-infection in Lyme patients. In one series in Long Island, New York, 67% of Lyme patients were seropositive for Babesia. Fever, sweats, headache, air hunger, cough, profound fatigue, balance issues, cognitive dysfunction, and Lyme symptoms that are worse. And treatment for Lyme is inhibited by Babesia being present. So it's really nasty. If it's there, you have to know about it. The other symptoms Babesia can cause, like the fatigue and the body aches, of course, that overlaps with Lyme, and there can be confusion. Transmitted by the same ticks that can transmit Lyme. In America, the two dominant species are Microti and Duncani, but there's also MO1, Otocolii, divergens, also some atypicals are occasionally seen. And again, now that we have a culture for Babesia, when sequencing was done, some really bizarre Babesia-like organisms were found. And right now, as I can tell you, the lab is getting sequencing done by outside agencies to try and figure out what they found, because they're finding things that you would never expect and standard testing would never, ever pick up. What are other standard testing? Stained blood smear. You can do that in hospitals early in the acute phase within the first week. After that, the germ load goes down. You can't see it even though it's still there. So stained blood smear in the hospital, not in the clinic. FISH is far better. There's one published study where the sensitivity was 100 times better than a stained blood smear. Again, this FISH is a genus level, so it's very broad coverage. The IFA, again, insensitive, it's outdated. You'd have to do separate IFAs for all the different species, and that's not available for the other ones. Immunoblot, besides being better than the IFA in terms of sensitivity and specificity, you're going to get the broad coverage. And now we have a culture, as I said, genus level, detecting some really weird things. Good test. Recommendations, just like as I said with Bartonella, it's very difficult to detect. And because it's very complex in terms of its parasite biology, there's no one test that's 100%. And finding the atypical species really reinforces that. So you've got to do the highest sensitivity testing and the broadest coverage. Multiple methods. Again, this sounds like everything else because it's true. Immunoblot for the best serology, a FISH and culture for the best direct testing. If there's a known B cell defect, substitute the T cell test for the immunoblot. In some cases, you may want to do both immunoblot and the T cell test because you want to track the response of the immune system and seeing if it's recovering during treatment. Rickettsias. We often don't talk about these. Actually, rickettsias, if you look at series of what they find in ticks here in Europe, Asia, actually there are more rickettsia species in ticks than even the Borrelia, Bartonella, and Babesia. So you can't really ignore these. And I've had some surprising cases of patients where we never suspected they had a rickettsia in their bloodstream, based on symptoms, based on whatever. But you know, some very astute labs have called me up on the phone and said, believe it or not, we found Rocky Mountain fever or Ehrlichia in your patient that you never expected. So you've got to include this with your testing, okay? Especially because in some cases, acute rickettsial infections can become rapidly fatal. In my own experience as a patient in my local hospital, wasn't my patient, someone else, came in with a fever of unknown origin, and he was put in the ICU and many different antibiotics, didn't know what he had. I eventually, unfortunately, died. He was in his late 30s. And the autopsy that was done showed an embedded tick in his navel. They never saw it. And of course, they found an Ehrlichia in his blood. Anyway, so acute presentations, acute fever can be very high, really bad headache, like your eyes are being poked out, severe myalgias, malaise, not so much joints, more the muscles. Often there's low white cell count and low platelet count. Some patients have elevated liver enzymes as well. In Rocky Mountain spotted fever, about 80% of the time, maybe 85% according to literature, there's this vascular rash that can extend to the palms and soles. And a rash like this, you can see from the pictures, are like red spots. If you press on it and let go, they blanch with pressure. And when they refill, it refills from the center. It's like a little blood vessel that's spreading out. In the Anaplasma and the Ehrlichia, you can get a rash like this, but it's much less common. Reports about less than 5%. Testing for these. Looking at Anaplasma, we have the serology, the IFA, and now we also have the culture. the very first time you've been able to get a clinical culture for these organisms, and definitely replaces the standard PCR and any other direct test. And you probably still do the IFA anyway, because you can get a faster turnaround, but the PCR you definitely want to replace with the culture, because that's much better. And as I said, they found some weird things in the blood you would never expect and never otherwise find. Now, in the case of Rocky Mountain spotted fever, you're stuck with the standard PCR and IFA, because believe it or not, to culture these, the labs are required to do biosafety level 4 in their labs. So labs are not basically able to do that. So we can't give you guys a culture for Rocky Mountain spotted fever, but we can for Ehrlichia and Anaplasma. And again, because this has such a high risk illness, we recommend that you do as many tests as possible. In other words, do the culture and the IFA, do the PCR and the IFA for Rocky Mountain. Don't do just the one test. And we're getting toward the end, and I'm not even overtime. Love it. All right, so the conclusions. Tick-borne disease testing, the reliability is not optimum. We're making advances, as you've heard tonight. The key is to know the performance characteristic of each test, when they're most sensitive, when they're least sensitive, who they're best to be used in. That's going to help guide you to choose which ones to order and when you're going to order them. Knowing the pathogen behavior can be helpful too, as I've shown. The highest yield is obtained when you do a panel of tests. You want to do indirect and direct tests. You want to do a test that'll look for different organisms, for different methodologies. And again, use a lab that's transparent with their test performance. You know, I've done a number of webinars for IGeneX as well as for others, and it's the only lab that I can report on that says we have used CDC samples, we've gotten specificity and sensitivity numbers and so forth and so on. I don't know of any other lab that does that right now. So again, if you're going to do the best for your patients and do the best for your reputation, you want to have a lab that you can stand behind. And if you criticize, you can use their data to say, wait, going to CDC's own test samples, this has shown such and such a result. So, you know, use a good lab. It's better for you. It's better for the patient. It's better for everyone. Despite all this great stuff about labs, clinical judgment has to prevail. You know, you're a clinician. These are clinical diagnoses. The lab is there to help you out. And your clinical judgment is the bottom line when you're diagnosing and treating your patients. But also, as I've explained, your judgment is now helpful knowing this knowledge about what tests to order and when. And so now I am done. I can say thank you. I'm going to give this back to Noah. Noah, are you there?
I am here, definitely here. I would
Thank you.
suggest stop sharing your screen real quick.
Okay.
I have
Here we
one
go.
follow-up question here from
right.
Evelyn, who is one of our attendees today. She asked, what does IGeneX IND result mean? It's assumed to be a positive, but how so?
When you have what's called IND, an indeterminate result, it means that these are serologic tests. It means that some antibody is present and they're picking up something. Now, why is it indeterminate and not a clear positive? Well, because the antibody level has been found, but not high enough to pass their standard of what's positive. So what that means is either, if it's a test like a Western blot, there might be some other organism that is giving a cross reaction to it. Or if it's something like an immunoblot, which doesn't really cross-react much, you might have to think the patient might have a weakened immune response. So an indeterminate result is actually good information because it gets you to look toward a different direction, looking at the immune response. Now, let me just back up. This indeterminate kind of result originated with IFAs and ELISAs. And when you get an IFA or an ELISA, let's say you get a positive, a borderline, or a negative, what is a borderline? Well, that's based on statistics. What most labs use is a standard deviation 2 above the negative control is an indeterminate, and 3 standard deviations is a positive. Statistically, 2 standard deviations works out to being about 93 to 95%, and a 99% is what a 3 standard deviation is. So if you get an indeterminate, you still have a 93 to 95% confidence that that's a positive. So I know I talked a lot, but I hope my explanation is something.
Yeah, I think that's one thing that you always bring to the table, Dr. Burrascano, is you shared almost a 50-slide, 60-slide PowerPoint very succinctly within an hour. You keep it, to the length that we want, and I think
And I haven't even had caffeine.
Very grateful for that, and I'm sure all the attendees with us today are as well. I just
Thank
want to
you.
reiterate to everybody that this is fully recorded, and I will be sharing around tomorrow the recording because I know because it is so much information, it might be hard to take everything in one sitting. So we'll make sure to share that around. So grateful for Dr. Barascano for giving his time to answer all these questions and provide information. So thank you so much for being with us today. And thank you, Dr. Barascano, for your work.
My pleasure. Happy to help. And I hope this has helped everyone else too.
Yeah, it seems like it has. People are definitely, I see a couple questions coming in if it will be available online. I just want to reiterate, it will be, and with Dr. Barascano's permission, I will include his slide deck as well.
Yep, you have my permission. I mean, I packed it really full, obviously, as you can see, and I don't expect everyone to pick it up at the first look at, but it's a reference, you can use it, go back to it, you don't leave it all in one sitting.
Yeah.
And that's great of you to offer it, so thank you for that.
Yeah, of course. Well, thank you everybody for being with us today. I'm going to go ahead and end the session. Thanks again, Dr. Barascano. And like I said, keep an eye out for an email from me tomorrow with all of this information. Have a great rest of your night.
Take care.